Welcome to Dinet Discussions, speaker series. My name is Ellen Driscoll. I'm the president of the board of directors of Dinet. Joining me also from Dinet is Lauren Malak. She's the vice president of the board of directors. Hi, Lauren.
Hi, thank you so much for joining us again today, everyone.
This is the third video in a four-part series that will continue into the first week of November. Before we begin, I just want to give a quick thanks to our sponsor, Banana Bag Oral Solutions. They give all the benefits of hydration therapy without an IV. And it is a drink that's available in a couple of different flavors. And at the end of the video, you can see in our description, there is a discount code for anyone watching this video if you'd like to try it or learn more about the product. Today's session is Let's Talk POTS, how to identify and manage POTS, and it's presented by Dr. Satish Raj. And Dr. Raj is the professor of cardiac sciences, the Libin Cardiovascular Institute, the University of Calgary. Dr. Raj is responsible for much of the research that is used by many of our own specialists in treating POTS. His background in internal medicine, cardiology, and clinical cardiac electrophysiology led him to 12 years of clinical research at the Vanderbilt Autonomic Dysfunction Center, developing research and studies on POTS and vasovagal syncope. Dr. Raj founded the Calgary Autonomic Investigation and Management Center at the Libin Cardiovascular Institute of Alberta and the University of Calgary's Cummings School of Medicine. The clinic focuses on providing high-level autonomic care to patients in Canada with POTS, patients with syncope, and patients with orthostatic hypertension. In 2018, Dr. Raj co-authored with many other physicians a special issue for the silver anniversary of POTS. If you haven't seen it, I strongly suggest you go onto PubMed and you seek it out. It's truly a comprehensive resource for POTS patients and for medical professionals. Dr. Raj continues to produce research and studies that are essential to the treatment, diagnosis, and quality of life for POTS patients. In fact, if you use Dinet's information resource articles to educate yourself about the disorder, you will see Dr. Raj quoted throughout. We are very honored to have Dr. Raj serve on Dinet's medical advisory panel, and we are very excited to have him share his time with us today. Hello, Dr. Raj. Thank you so much for being with us today.
Thank you, Ellen. Thank you, Lauren. Thank you guys for having me.
I'm going to turn this over to you, and we will be back with patient questions at the end of the session.
Wonderful. Let me get the slides up. I'm hoping you can all see that.
Yeah.
So I guess this will be a fairly summary or basic overview. There are lots of divots and complications, as those of you who've lived with POTS probably have realized already, and we don't obviously have time to be comprehensive and go into every possible nook and cranny, but I'm hoping to give you an overview of POTS, a little bit about how we think about it, and in some ways that hasn't changed in 25 years, in some ways it's evolved in the last 5 years. So we'll cover some of that and some treatment approaches that we use here in Calgary. So I guess the first thing, just in terms of defining POTS, the important thing is that there are criteria that both hemodynamics. So the hallmark cardinal feature is the tachycardia, right? And it's an orthostatic tachycardia, and I'd go a step further and say it's an excessive orthostatic tachycardia. And I say that because orthostatic tachycardia isn't abnormal. We all should have it. In fact, if we don't have orthostatic tachycardia, that can sometimes lead to a different set of problems with orthostatic tolerance. It's part of our adaptation to standing. The issue in POTS is that instead of going up a little as it should, it can be quite excessive, and to the point where it in of itself can contribute to symptoms. The threshold used in adults, and this goes back to the Schondorf and Lowe criteria from almost 30 years ago now, is an increase of greater than 30 beats per minute from lying to standing within 10 minutes. One of the issues, though, that has come up is that orthostatic tachycardia, the physiologic orthostatic tachycardia, is higher when we're young and decreases as we get older. And the static number doesn't account for that. And one issue was highlighted by Wolfgang Singer and the group at Mayo, where they actually went and performed orthostatic vital signs in the schools around Rochester, Minnesota. And what they found was that there were a lot of kids, teenagers, early teenagers that had orthostatic tachycardia well beyond 30 beats per minute who were otherwise perfectly healthy. And we risked medicalizing them for the wrong reason. And so the criteria several years ago was redefined with a higher threshold for those, it says less than 18 years, it's actually between 12 and 19 years. And it's important to note, at least in North America, we don't actually have a heart rate cutoff for under 12 years old, although I believe there's some Chinese criteria where they have some definitions, but not yet accepted in the West, if you will. At least it hasn't made it into the guidelines. Importantly, this is in the absence of orthostatic hypotension. And that's because we've known for a long time that people, when they drop their pressure, so any of us, and me, if I had a bleed, let's say a bleed in my gut and lost blood, I would probably, and to the point where I had a drop in blood pressure, I would have a rip-roaring tachycardia. It's part of the body's adaptation, its attempts to adjust. So the whole point is the treatment of that is the treatment we'd approach for orthostatic hypotension. What we're saying with POTS patients is even without that, there's this excessive tachycardia, and why is that? So usually, if the tachycardia is only occurring in the presence of orthostatic hypotension, that's not POTS. That's not to say the POTS patients can't occasionally drop their pressure and have orthostatic hypotension and still have a diagnosis of POTS. But the issue in terms of the coexisting diagnoses are that if you actually only have tachycardia in the setting of hypotension, it's not that you have nothing, but you have a different disorder, and we don't call it POTS. We call it orthostatic hypotension, and there are treatment algorithms and approaches based on that. So, so far I've described POT. Legal in Canada, by the way, for anyone interested, has been for a few years now. But it's not POTS, right? The key to POTS is the S. POTS is a syndrome, and syndrome means that there are a bunch of symptoms that make this group of patients look like this other group of patients from which we can try and learn approaches and a starting point for treatment. And that's key, right? So tachycardia in and of itself is not enough to have a diagnosis. You need orthostatic symptoms. And by that, I mean symptoms, many of which are, and dominant ones that are worse when you're upright and they get better when you're lying down. That's not true for all symptoms, right? So I'm not saying that every POT symptom has to be worse when they're upright. There are certainly some that occur without regard to body position, but if the symptoms aren't predominantly worse when upright, again, not POTS. And finally, the symptoms have to be chronic. And I have 6 months here. We've probably veered towards 3 months, and maybe we're quibbling over, a definition that's not as relevant. And what I mean by that is, I don't see a lot of patients that are very symptomatic at 3 months to get better by 6 months. But I think it is fair to say that you see patients that are sick acutely, say a week or two, that do get better. And the reason for the chronic criteria is that a lot of what we're going to be talking about in POTS and their symptoms, I suspect that if you go to your relatives that don't have POTS and wait until they get sick with a bad cold or a flu or nowadays even COVID, acutely they will look like they have POTS, right? If they want to do experiments on themselves at that time, we can do the orthostatic vitals when they're sick and ask about some of the symptoms, and they will meet a lot of the criteria. So the issue isn't that this is unique. The issue is that most people, when they get a cold or a flu, they get better in a few days. Sometimes it lingers for a couple of weeks, but the issue here is it doesn't, right? It lingers for months and months and months and maybe years, but certainly we require a chronicity to it. So a couple of years ago, we published through the Canadian Cardiovascular Society a POTS position statement. And this is available open access for anyone that wants to go and find it, and the citation is listed here. And one of the things that we sort of wanted to acknowledge is that there were lots of symptoms in POTS patients sometimes that were well outside of the tachycardia issues, well outside of the lightheadedness issues, and important to acknowledge because they probably require treatments outside of those treatments that I'm going to focus on today, right? I think generally speaking, we're better at treating some of the tachycardia and lightheadedness issues. And I disagree with those people that say that's actually not important, because I think in many patients, it depends on the patient, but in many patients where those symptoms are dominant, we can actually improve their quality of life a lot. But if someone's main dominant complaint that's really bothering them the most are issues with gastric emptying, and they also have the tachycardia issues, just treating the tachycardia alone is not going to make their quality of life completely better, right? I mean, it may help a little, but their dominant issues aren't addressed. And so here we just list some. I'm not going to go through all of them in any detail. I think several of you watching will be familiar with many of these probably, but these are sort of other issues to consider that we see traveling along with POTS. It's not to say that POTS is causing them. It's not to say they're causing the POTS, but they do travel together and do require treatment. And I find sometimes when someone gets a diagnosis of POTS, other specialists sort of try to blame everything on their POTS, and as if to say, go to the POTS doctor and holy water will be dripped on you and everything will get better. And the truth is that that holy water doesn't exist, at least not here. I mean, maybe Lourdes, but here the holy water doesn't exist. And really we need to take advantage of people with doctors with expertise in these different areas to help out. So often it takes a village of doctors, to paraphrase an old phrase, to help really deal with all these issues. One of the issues that we wanted to emphasize in the Canadian Cardiovascular Society statement is, not sure, probably another slide I probably should have had showing this, but one of the issues that we wanted to emphasize was that POTS requires orthostatic tachycardia physiology and orthostatic intolerance symptoms. And if you don't have both, you don't have POTS, right? Because we find that the problem with the diagnosis of POTS is that in many cases, patients present classically and the diagnosis is not made because their doctors don't know about it. But we also are starting to have a problem with people getting a diagnosis of POTS where they don't meet POTS criteria because they have some features that look like POTS, and there's nothing else to call it. And so we wanted to try and create an ecosystem, for lack of a better phrase, of disorders of orthostatic intolerance. And we created a Cartesian plane, which I didn't show here, but a flow diagram that doctors or patients could try to use to sort of walk through what we had. So the first question was, do you have orthostatic tachycardia, right? And if you do have orthostatic tachycardia and you have orthostatic intolerance, and it's not due to another cause that's reversible, then you have POTS. Okay, but what if you have orthostatic tachycardia, but you don't have orthostatic intolerance? Well, if you have tachycardia and you don't feel unwell, then for the most part, you can ignore it. And that may seem like a silly thing to say, but we live in a Fitbit and Apple Watch era now where people are aware of every heartbeat that doesn't seem quite right. And so you have the worried well, right? Not probably the people on this call, but those people are out there. The bigger issue is, what if you don't have orthostatic tachycardia? Well, if you don't have orthostatic tachycardia, but you have a resting tachycardia, your heart rate's always fast, then you may have what's called inappropriate sinus tachycardia, or IST. But the bigger issue is you don't have orthostatic tachycardia, but you do have symptoms. You do feel unwell, and we see this commonly, at least not uncommonly, right? If the answer is you have that, then we created this nomenclature, which is awkward, and maybe people will come up with a better term, called postural symptoms without tachycardia. Right? So these are the people that look like POTS. They have symptoms that are similar to those seen in our POTS patients, but their heart rate increases don't meet criteria. Some cases they're stone cold normal. In some cases they're a little above stone cold normal, but they don't reach the threshold that we've set for POTS patients. And in this, just like in POTS, where we've created this plus category for people on the prior slide where I listed a bunch of comorbidities that can be dominant, like Ehlers-danlos syndrome, like mast cell activation syndrome, like certain autoimmune neuropathies. Basically, if you just have the postural symptoms without tachycardia without those things, it's just postural symptoms without tachycardia, or PSWT. If you have those things, we've added a plus. And the plus just indicates there are these other issues besides the orthostatic issues that may need to be dealt with. And one could say, well, that's great. You spent a lot of time just creating a whole new bunch of labels, and maybe that's correct. But there's a reason that we did that. And the reason we did that is it becomes very difficult when wanting to study patients with POTS or these related disorders if you're clumping people in that don't meet the criteria. And it becomes difficult when you're talking about POTS and therapy X or therapy Y improve quality of life without knowing, well, if the quality of life didn't improve, is it because they had dominant gut symptoms? So you fix the things that your drug or your treatment was going to fix, but they had other symptoms that you weren't addressing. And this is a way of trying to capture a bit of that. So we've thrown this out. We'll see if it sticks, right? It's a relatively new classification that we came up with to solve a problem we thought existed. It may not be correct, right? I mean, that the science and our approaches to these things are iterative. And we'll have to see if this turns out to be useful for folks or not. So common symptoms, we've sort of skirted around this. This is my approach to it from a cardiology point of view. I've broken the symptoms down into things that could be considered heart-related or blamed on the heart or vascular system on the left, and symptoms on the right, like mental clouding and headache, common symptoms in POTS patients, but ones I have more trouble directly blaming on the heart. Similarly, the symptoms in black are things that do tend to get worse when you're upright. They can exist supine, but they tend to be worse with upright posture, while there are symptoms in blue that probably aren't positional at all. So sleep complaints are very common in POTS. They're not worse if you sleep upright than if you sleep lying down. They're just bad overall. This is the hallmark of POTS. So this is a slide of a tilt table test in a control subject, a healthy control, which when I was at Vanderbilt, you could just sub in Vanderbilt graduate student for healthy controls. That's who they were on the right, and the POTS patient on the left. And we have a heart rate channel on the top, blood pressure, continuous blood pressure in the middle, and the tilt angles. You can tell when the table went up and when it came down. And you can see when the table goes up in the control subject, blood pressure stays about the same, goes up a tiny bit maybe. The heart rate goes up, right? So again, orthostatic tachycardia is not in and of itself abnormal, right? It's physiologic. It happens in our healthy subject. But if you look at the POTS patient on the right, when the table went up, the blood pressure on average, probably not different than the control subject, certainly not low overall. You could correctly look at this and say, but it looks different. It sort of looks like I do, on a bad hair day when, I'm desperate need for a haircut. It's just all over the place. But the average isn't low, right? Fundamentally, POTS patients do not have orthostatic hypotension, and that's what this is showing you. But if you look at the heart rate channel, the heart rate went up aggressively. It went up a lot, it went up fast, and it kept going up. It kept going up until the patient told us to stop. This is a 30-minute protocol, and the patient did not make it through the 30-minute protocol. And the reason that the patient told us to stop was that her heart rate was 180 beats a minute. And all we did was tilt her up, right? So again, this, when presenting stuff in textbooks and in meetings, you present your worst typical case, right? The truth is most patients don't get the heart rate up that high, right? But it does happen, right? But it's an extreme version of what we do see. And I mentioned earlier, and I'm going to emphasize it again, the key is symptoms, right? So we actually rated symptoms in this study. The control subjects, the healthy control subjects are in black, and you can see for the most part, they're asymptomatic, except when they were symptomatic briefly, and then they'd faint, right? And so they drop out, which is why the symptoms got better. The POTS patients, interestingly, were symptomatic from the beginning and just kept getting more and more symptomatic. The interesting thing, and one day I will actually put this bit of data up because I keep saying I will and I haven't, is that more of the POTS patients made it through the full 30 minutes than the control subjects. The control subjects actually had a few of these folks faint on us, and so they didn't survive the 30-minute tilt. The POTS patients, on the other hand, told us very early that they were going to faint, and they kept telling us for 30 minutes they were about to faint, right? And the point of that is that POTS is a disorder, not a fainting. It's not a fainting disorder. It's a disorder of feeling faint. So some POTS patients do faint, right? But it's a minority of POTS patients that actually faint. It is almost universal those that feel like they're going to faint, right? And that's driven by the heart rate and other things. So, we had done a lot of work at Vanderbilt, very detailed physiologic studies. That's where my heart is. But one of the challenges is we always wonder whether the patients that come and see us at Vanderbilt, some of whom have traveled across the country, really represent the more general or the broader population with POTS. And so we created a large online patient survey. There are a series of papers coming out of that, but this was the first paper published a couple of years ago called the Face of POTS, right? Just a broad description of what patients describe and sound like. So what we found to some extent was reassuring, I guess, and that is that the demographics that we sort of had from our studies and Mayo had from their studies was probably pretty close. Somewhere around 90 to 95, I think it was 93, but somewhere around 90-95% of the patients were female. This was largely a US, like probably 90% of the respondents are American, but there were smatterings of patients from around the world, overwhelmingly white, north of 90% again. I think again, approaching 95% were white. Now, if we'd done this study in other places, would that be different? Possibly, right? There, it was fairly democratic in that it was a link that you could access, but you had to have computer and online access. And importantly, the survey was in English, right? So we did exclude those that weren't able to participate in English. And so that probably does affect the racial distribution somewhat. When looking at the age of POTS, the most common age was 14, okay, which reflects a large pediatric bump, but almost half the patients were over the age of 18 at the onset of their symptoms, right? So it's not just a disease of adolescence. There's a big bump in adolescence, particularly adolescent girls, but then there's also sort of a secondary bump or a prolonged tail, if you will, into adulthood where people do get it later in life. And this is important because this may reflect, I think, another common truth about POTS, and that is it's not a thing. It's probably due to a bunch of things, and different mechanisms are at play in different patients, which complicates our ability to come up with short, simple answers as to what it is and what to do about it. From the survey, again, this is published as well, and I believe it's open access as well if you're interested. The first paper, we listed common symptoms. We had a laundry list of symptoms and had people say yay or nay. And the most common symptoms, in well over 90%, lightheadedness, tachycardia, presyncope, the cardiac symptoms you'd expect in a disorder with tachycardia in its name, right? But the next three, headache, and over 90%, difficulty concentrating, the so-called brain fog, probably about 90%, nausea and just under 90%. Again, not directly heart-related, right? Or at least not obviously heart-related. So it just reflects that these symptoms, there are a bunch of cardiovascular symptoms, but it's a multi-system disorder. The vast majority of patients, worth noting that we had about 5,000 patients complete this, right? So this is a fairly big survey. 83% had another medical condition that they listed. Migraine headaches were the most common, irritable bowel syndrome, but 25% have Ehlers-danlos syndrome. And somewhere in the 25 to 30% range, is about what we see across multiple studies. I'm always suspicious of those numbers because it seems like the Ehlers-danlos folks change the criteria every few years to confuse me. And you always wonder if the diagnoses are being made correctly. And this doesn't answer that question, but it does say that at least the different groups of investigators are at least consistently making the same mistakes so that the numbers are consistent across the studies anyway, right? And it's about in that 25 to 30% range. Some Raynaud's, gastroparesis, less common than irritable bowel. So I often think of the gut as almost two different organs. The stomach and the front part, seems to respond a bit differently than the colon and the bottom bits. And vasovagal syncope, interestingly, only about 15%, 13% in this series had. My suspicion would have been that it's a little higher, but again, not the majority. Worth mentioning in here that there's several disorders that are autoimmune. We bundled them all together, and about 16% had sort of a coexisting autoimmune disorder, but not one dominant autoimmune disorder, right? So some had the thyroiditis, some had Sjogren's, some had lupus, some had rheumatoid arthritis. It was a hodgepodge of different things. Education. So this is important because of the number of kids that get it. The mode of onset is 14. This is an age when kids are starting or in high school often, right? And almost all the patients missed some school, but 30% were homeschooled. We didn't ask specifically. I suspect most of this was for medical issues and not religious issues, but I lived in Tennessee. There are a bunch of people that homeschool for other reasons. Almost a quarter had to drop out of school at some point. And 40%, higher education either delayed their advanced education or postponed it because of their illness. So, I think this speaks to sort of, not just the impacts today, but the potential long-term impacts, right? We're sort of, this disorder is affecting lots of kids at a fairly critical age in their life where arguably the trajectory for their life is being mapped out, right? And so it is important that we try and get sort of on top of this and try and get them functioning, if not totally better, fairly quickly. What about quality of life? So this is not our data. This is published data from using the SF-36, which is a generic quality of life tool. The problem with generic quality of life tools are they say nothing about the things that are really important to the POTS patients. But the nice thing about it is you can compare it across disorders and diseases. And so these are two disorders that are generally acknowledged as having a pretty crappy quality of life: patients with chronic back pain and patients with end-stage renal disease on hemodialysis. And we had used a similar tool in our POTS patients, and these are their data overlaid, right? So the point here it's not addressing the why, it's not addressing the should it be, it is merely saying that when self-reported POTS patients report a quality of life that's comparable to patients on dialysis. This is several years ago, we had done that as part of a larger sleep survey, and I apologize, at one point the slide had dots on it, but you'll have to take my word for it that these lines aren't totally made up and are regression lines through dots. But we had POTS patients and healthy controls, and what we found is that there was a spread in the reports of their subscores for physical health and mental health in terms of the SF-36 scores. And for both, about 60%, the R-squared was about 0.6 or 60% of the variance in that domain of quality of life could be accounted for by the quality of their sleep or the sleep problems, but this is sort of the inverse of the same thing, right? So sleep does seem to play an important role in the quality of life in these patients. Okay, so what are we going to do once we sort of say they have POTS? The basic investigations really aren't that complicated. Maybe they will be at some point, and in some individuals they should be, but we don't recommend sort of the one of everything approach, which I know some folks advocate for. The key is really a thorough history and physical. And when I say thorough history and physical, I mean a thorough history, more history still, and then some physical, right? Most of this isn't about abnormal physical exam findings. There's some things that should be done, but a lot of it is trying to understand the pattern of what's happened, right? Often it's a long journey. These visits are not fast, right? It takes time to sort of understand what's happened and what symptoms that seem unrelated may actually be linked. Orthostatic vital signs are critical, right? And whether that's on a stand test or a tilt test, you can't make a diagnosis of POTS without determining whether you have orthostatic tachycardia or not. And then in the Canadian Cardiovascular Society position statement, there was a very basic core bit of blood work that was recommended: a CBC, basic metabolic panel, thyroid test. You could consider adding a baseline cortisol to it to rule out Addison's, but a few things to pick up quickly reversible causes that you want to get to. I probably should put here an electrocardiogram was recommended by them. The yield is low, but you can rule out some things you wouldn't see otherwise. And that's it. If you came to see me, we'd probably get autonomic reflex testing, but that's because we're sort of not the first line of defense, if you will, but a tertiary center where we can learn a little more about autonomic physiology. I think it's important that the physician be confident that the heart is structurally normal. There are certain types of cardiomyopathy affecting in our demographic postpartum or peripartum cardiomyopathy that occurs at the tail end of pregnancy or just after, can present with tachycardia and a lot of similar symptoms, but the problem is the heart, and the treatments are very different. So if by exam you're confident that hasn't happened, great. If you're not sure, then an echocardiogram may be reasonable. And if you're seeing patients repeatedly, sometimes a blood volume assessment and exercise capacity assessments can be useful. the truth is I'm a big fan of understanding blood volume, and I think a lot of our treatments are targeted there. It's in Canada, it's hard to get right now. But I know when I was at Vanderbilt, we get it a bit more frequently. It can be helpful in terms of how hard to push on volume replacement, although there's an element of it we do for everyone. So the mainstay of therapy, the foundation of therapy, are non-pharmacological approaches. And this is the pretty much for everyone. And so it starts with, increased salt and water intake, compression garments, and exercise. And we'll touch on each of these before we get to the drugs. So, for years, and I suspect most of you have probably heard this from your physician, when you go in with symptoms, they say, take more salt. But surprisingly, the data for that in POTS was essentially non-existent, right? There's a little bit of data in syncope, but there wasn't a lot of data. And so we actually did a study, and this was NIH funded. Most of it was done before I left Vanderbilt, but we only got around to publishing it earlier this year. But we basically did a study which involved bringing in POTS patients and healthy controls to the Vanderbilt Research Unit for 2 one-week stays, about a month apart. Our participants were all women, so we wanted to try and keep it in roughly the same phase of the menstrual cycle, because that can affect volume status. And in one of the weeks, we had them on a very low sodium diet, and one of the weeks we had them on a very high sodium diet. And what we wanted to know is whether salt did what we think it did. And the short answer is it did, right? And so what do we think it would do? So we give people salt to try to increase their blood volume, right? And that's shown in the bathtubs with various amounts of water here. And the whole idea is that we think that the low blood volume that a lot of patients have, and did a lot of work showing about 70% of the POTS patients when we were doing it regularly at Vanderbilt had a measurably low blood volume. We think that that's actually a driver for increased sympathetic nervous system tone. And the neurotransmitter there is norepinephrine, and we would fairly commonly measure that lying and standing in the blood. And so we thought the increased volume would lower the standing norepinephrine. It would decrease the pressure on that. And we thought the norepinephrine was then driving the heart rate. So by doing this, we'd lower the heart rate. Right, and I'm happy to report it did what we thought it would do. Right, it was an aggressive salt approach, but it did work. And so we finally had data to support that. So that's fine, say take more salt, but what does that mean? So in our clinic, this is sort of more the approach I take, the practical approach. And that is, I try and get patients to drink at least 3 liters of water per day. Is there specific evidence that 3 liters is the magic number and it's not 2.5? The answer is no, right? But the goal is, my sense is that 3 liters is probably more than people need. It's a safe level. It's not going to cause major problems, and it takes work, but it's doable, right? But to do it, I tell my patients, and many already have this, you pretty much need a water bottle that you like, that you keep with you all the time, that you fill, you drink, and you have. If you drink water when you're thirsty, you will never get to this level. So the first is water, and the second is to get in salt. And we talk about 8 to 10 grams, 10 to 12 grams. The truth is you can make up whatever number you want. Some people like the numbers, but I personally cannot sit there and add up the various milligrams of sodium I'm getting in a day in any meaningful way. And so I've gone away from that, right? I've sort of tried to take that target and rework it. And so what I try and get people to do is to take 2 teaspoons of salt. I start with 1 teaspoon, go up to the target dose of 2 teaspoons and put it in a Ziploc snack bag. And when I say Ziploc, I use the term generically. If GLAD wants to sponsor me, I'm happy to try and push Ziploc specifically, but right now you go to your local grocery store and buy the no-name brand if you want, right? Put it in a little snack bag in the morning, and then it's your job to get that in you through the day. You can do it however you want, right? So for most people, adding it to food is what makes the most sense. So instead of shaking it on with a salt shaker, you take it out of the bag. Some people don't like the food then. I have a few patients that add it to hot water and lemon juice and will drink it. I get nauseated just thinking about that, but it works for them. I have some patients, younger patients, that actually add like 1/3 of a teaspoon to a shot glass and do shots. It's sort of like a margarita without the good stuff. You can't say no to everything, Lauren. The point is that I don't care how it's done. You have to find out what works for you and get it done. And this works for most people, and I prefer this to salt tablets. The only advantage of salt tablets over this approach is you don't have to taste all of the salt. So if you hate the taste of salt, And truthfully, most of my patients don't hate salt. If anything, more crave salt than hate salt, but some do. If you hate the taste of salt, the advantage of the tablets are that you just have to taste the bit on the outside, the other stuff's on the inside, and you don't have to taste it all. But I think actually an increased risk of more gut grief because you get very high concentrations of sodium in one very specific part of your stomach when you take the tablets, while with the granulated salt you're taking in, it's spread out. One more word about the salt. I have patients coming to me, trying to argue that some type of salt, like the Himalayan sea salt, is better for you because of the minerals. I think that's total crap, right? What is true is the Himalayan sea salt tastes different because of the minerals, and it may taste better. And I think, the regular salt you buy in the store, when you take a lot of it, actually can have a bit of a bitter taste. And if you're more likely to get it in because it tastes better, and yes, it works better, right? Because you're more likely to do it. But I think any salt that you get in is actually what you need to get in, right? And go ahead and buy more expensive salt, because the truth is, compared to most drugs, it's cheap, right? Even the most expensive salt is going to be cheaper than most drugs you take. So find something that works and do that. If you really can't tolerate the salt at all because of nausea, then there are gel-coated versions. So Vitasium is one brand that's available, I know, on Amazon, probably available in other places. There's a POTS version. It comes with 250 milligrams per tablet and a little bit of potassium, right? But if you're taking, say, 2 tablets a day, right? And so the issue boils down to 2 grams of sodium, right? So that's about, say, 5 grams of salt. That's 8 tablets a day. And so the issue is it can get expensive because you go through the tablets fairly quickly, right? But there are different approaches. And for most people, just stuff you buy at the grocery store will work. What about compression? Again, this is something we've been recommending for several years. The whole idea is that when we stand up, fluid shifts from our chest to below our chest and doesn't get back to the heart. It drops cardiac venous return. And we thought, well, that lowers the stroke volume, the amount of blood that the heart pumps every time it beats. And so if you need to churn more blood, you need to increase the heart rate. And we thought that was a driver. And so we did a proof of concept study. Kate Bourne, one of my PhD students, led the study looking at compression. And we used a sort of a segmental compression suit. And what we found is that if we use sort of a full pantyhose style configuration, so abdomen, thighs, legs, that the heart rate, of course, went up when we tilted the person up, but then it sort of plateaued, while without the compression, the heart rate kept going up. So it actually significantly decreased that. And we actually did different configurations. We did everything, nothing, but also the bicycle shorts approach, abdomen, upper thigh, as well as the calf. And what we found was actually that if we looked at heart rate and symptoms, we found very similar findings, and that is that full compression was the best. Abdominal compression was close, not quite as good, but pretty close. And leg compression, like the calf compression, was almost like doing nothing, right? So people that wear compression socks that go up to their knees, I tell them that if they look nice, go ahead, because it's largely decorative, right? It may help prevent clots in your leg, but it's not going to help squish blood back to your heart, which is really what we want. So if you're going to do compression, ideally pantyhose style or waist-high compression stockings or tights. We often recommend going to a sporting goods store and purchasing sort of high-end athletic wear. Or if you can't do that because it's too hot to wear, fortunately I live in Calgary where we only have weeks where it's too hot to wear these things all year, and the rest of the time it's cold, so the full compression works. But if you're somewhere warmer than I am, we don't have any data for this, but we've been recommending body shaping garments like Spanx. Again, focused on upper thigh to bottom of the rib cage, just focus on the abdomen, sort of pelvis area, not other areas. What we're excited about is not only to lower the heart rate, but this slide isn't of heart rate, this slide is of symptoms, right? And we showed that we improved symptoms with this. And in fact, there was a good correlation shown here on the right between the drop in heart rate, or the drop in the orthostatic tachycardia. So it's actually the drop in the increase in heart rate, and the improvement in symptoms, right? Where the more you compressed, focused on the belly and all, actually made things better. So what about exercise? I mean, I think a lot of you have probably heard lots of things. Our approach is version, I guess, of the Levine protocol. I think for those that are, have a trainer, an exercise physiologist you're working with, you can get calendars online from their protocol for up to 6 months at a time, I think. The truth is I am not smart enough to read them, right? They speak exercise physiology. I don't. I don't understand them. They had patients off all drugs when they exercised. I often have patients on drugs, including beta blockers, which messes up some of their targets. So I don't use them at all. What I tried to take from what they did is what the principles were, right? And that's what I have summarized here. The principles were that most of what they were focusing on was aerobic reconditioning, right? There's a little bit of leg resistance to build up a bit of muscle bulk in the thighs, but it's mainly aerobic reconditioning. So that means that if you're doing Pilates, good for you. Quite frankly, I ache every time I think about Pilates, but it's not helping in terms of your POTS, right? So you can do that and aerobic reconditioning. It's not an either or, it's not a substitution. The exercise that you do, the aerobic exercise that you do, frequency and duration are important, right? And so what that means is at least 4 times a week, every other day. So life gets in the way for most people, right? So I often encourage patients to try for 5 or 6 times a week, recognizing that you're going to lose a day here or there. You will, it happens. So you still end up at the 4 times a week. And each session fairly quickly needs to get to at least 30 minutes. Okay, and we'll talk about the implication of that in a moment. The most important thing is, at least in the beginning and maybe forever, we discourage upright exercise, right? Most people, when you say exercise, what they hear is treadmills, walking, running, those evil elliptical things, right? But they're all things where you're vertical to begin with, right? And if your heart rate is approaching your target heart rate before you turn the machine on, it doesn't bode well for how you'll do on the machine. So the whole idea is not to waste your heart rates on gravity, but to invest it in the exercise, right? And so swimming is good. It's not as practical for me where I am. There aren't a lot of pools. So for my patients, it's often more an issue of rowing machines or recumbent cycles. In fact, the modality preferred in the study was a rowing machine. Now they used fancy $3,000-$4,000 rowing machines in a gym. I hear that the Concept 3s have water in the front wheel. So when you pull, you hear the water swishing like you're on the lake. And I think it spritzes you with water, so you get like a mist. But I suspect if you offered a family member a chance to spritz you without even paying them, they'd probably be happy to do it for nothing. Especially if you have young kids, they probably enjoy that, right? You need the motion. So you can get cheap rowing machines for several $100s. You can go to a gym and do it. I find in my patients, if they can get cheap equipment in their home, it's much more likely to happen, right? But ultimately, it's up to the patients to figure out what works for them, because everyone's a bit different, especially in people with joint hypermobility, where certain joints are popping out. You have to figure out which motions work, right? I wouldn't dismiss any. I have patients that have hip and shoulder issues where I didn't think they'd be able to do the rowing machine, but it didn't actually bother them, right? So you may have to have them test it out and see. But if their hip or shoulder is popping out every time they pull, it's not going to work, but have to find something else, right? Swimming is often good from that point of view if you have access. The nice thing about the rowing machine and the recumbent cycles are that they usually have a resistance dial that you can turn up or down. And I encourage patients to turn it all the way down, turn it off if you can in the beginning. And then, I was occasionally getting patients coming back to me saying, well, I'm up to 4 minutes, I'm up to 6 minutes, and that's all I can do. And I feel like I'm about to die at that point. And the truth is, if you feel that way, don't keep going. Don't go and sit and say, well, Dr. Raj said, got to keep going. If you're at the point where you're about to pass out, you're done. But you messed up, right? Because with the rowing machine, if you've turned the resistance all the way down, the only other input is speed. And if at 6 minutes you felt you were done, that means you went out too fast. Now, it could be that your partner is sort of looking at you going, what do you mean going too fast? If you went any slower, you'd be going in reverse, right? Ignore them, right? You shouldn't be competing with someone else. You shouldn't be competing with your old self. The point is, go in super slow-mo if you need to, get to 30 minutes, right? And then build up from there. And I grant you, different people have different approaches to how to do this exercise. Some build up time-wise in little increments, but the I'm a fan of trying to get to the optimal time and make everything else easy as possible. And then as you do it, you will build up the speed and build up the resistance, and maybe build up the time further. Most importantly, you're going to feel like crap when you start this, almost universally. It can take 4 or 5 or even 6 weeks before you start to notice any improvement. And in that time, you may feel worse. So what I would say is do it if possible at a time when you can account for that. After the 6 weeks or less, it's easier to keep going because then there's positive feedback, right? Then people feel worse when you don't do it. But in the beginning, you have to fight what your body's telling you. We usually, if we burn our hand, we usually go away. And that's the problem that I think a lot of patients have with the exercises. Initially, you do feel a lot worse. Patients have told me that if they do this, they can't get out of bed for 2 days. And I don't recommend this because it's not that I don't believe them, but I have patients that have been through that have trained out of that. Now, I want to be clear. The exercise is not a cure. It's a treatment, right? You stop doing it and the benefits go away. And even in the Levine study, the POTS patients post-exercise that were able to complete this all improved, but they didn't resemble sort of the healthy control females, right? So it's a treatment that gets you more functional. It's not that this will all go away with this. So a lot of my patients may require drugs as well, but not all. Some with the non-pharm approaches, that's all they need. I'd say the majority require drugs also. So let's talk about drugs if we're going to get there. And we'll touch on a few of these quickly, and then we'll stop. So IV saline has gotten a lot of attention. I will say that acutely it works, right? So this is old data. It's almost 25 years old now. And what it shows is that an hour after receiving IV saline, if you look at the far right, the heart rate went from meeting the excessive orthostatic tachycardia criteria, it looks like it's about 33 beats a minute, down to an increase of about 15 or 16 beats per minute, which is normal, right? So acutely, it altered the physiology and improved things. Just doing the tilt, afterwards, shown on the left with placebo, does not make that difference. What I'll say is that I do use this. So if someone is decompensating and they end up in a merge and we're trying to figure out whether to admit the patient or not, my advice is usually to try and get the doctors to give the patient a liter or two of saline and see how the patient feels then. Because I think a lot of patients will feel better. The acute increase in blood volume often is enough that the patient is able to go home. The problematic area is when it comes to chronic use. And the problem is how to get the saline in, right? And you need to get an intravenous catheter. You need an intravenous catheter for that. And if that's done once in a while, that's fine. But every time you access the vein, you actually clot off a little bit of the vein. And so if you keep doing this, access becomes a big problem. It becomes very hard to get an IV in the future. And then there's a slippery slope that often leads to getting a PICC line and then eventually a portocatheter central line. And most professional guidelines recommend against that because of the access issues, because central lines have their own risks, and some of which are life-threatening risks. There are a couple of series that have been looked at on the use of IV saline chronically in POTS patients. One in a pediatric group out of Washington, which reported a much higher rate of complications actually than in other groups that had chronic lines, right? So if they compared to oncology patients that had chronic catheters, there was a much higher rate of line complications in this group. But there's a group out of the Toledo group actually published a case series where patients actually did fairly well without too many complications. But it's worth noting that the majority were on it for a short enough period of time that they never went to a central line. So I guess what I'd say about the IV saline is that if it's really only being used as a bridge, for a very short bridge, not a long bridge, like a short bridge across the driveway, not like, the Golden Gate Bridge, right? It may be reasonable, but there's a very strong danger of slippery slope because people do feel better with the IV saline, right? And it sort of lures you in, but then you're left in this difficult situation where you're sometimes left having to either give it up or feel a lot worse because you've almost in some ways become dependent on that approach. DDAVP is desmopressin. It's a drug it's on the market, I think, well, for different things, but one of them is to help 5-year-old boys who wet their bed, right? It encourages free water retention. You stop peeing. We've shown that with water does acutely lower heart rate. And we've tended to use it as a special event drug. So you want to go to a movie on Thursday night with friends, well, you don't know how you're going to feel. If you take this in the afternoon, chances are your blood volume is going to be expanded and people do feel better, right, for several hours. I rarely use it every day, but there is some data, I'm not sure if it's published, but mainly out of Toledo, where they were giving 0.2 milligrams nightly. Why I'm hesitant to use it more is that while it's safe enough that we give to 5-year-old boys, we don't tell 5-year-old boys to drink 3 liters of water. And retaining free water and a drug that prevents you from getting rid of it runs the risk of diluting out sodium and other electrolytes in your body, and that can actually be life-threatening as well. So if you're taking DDAVP, you must get your potassium checked frequently with your doctor. Or sorry, not your potassium, your sodium checked frequently. Because hyponatremia, the first manifestation can be neurologic and severe, right? So you want to pick that up before it's a problem. Very important with DDAVP that while little may be good, more is not better, right? More can be life-threatening. Let's talk about some other agents. So mitidrin decreases orthostatic tachycardia as well. This is from the same paper from 25 years ago. You'll recall that the saline, knocked the orthostatic tachycardia in half. The mitidrin took the edge off, right? So mitidrin does have some benefits. It's not in the same league as saline, but there is some data that it helps. Beta blockers, there are people that are believers and people that aren't. I'm in the big pro beta blocker camp. On the one hand, you have a lot of heart rate. Lowering it as a cardiologist is something we were always trained to do. However, a lot of patients that came to us at Vanderbilt reported being intolerant to beta blockers. And there's some data from Julian Stewart with esmolol that it didn't actually make people feel better. But when we studied it at Vanderbilt, we used 20 milligrams of short-acting or regular-acting propranolol. It was great, right? It lowered standing heart rate. It lowered the orthostatic tachycardia. Importantly, it lowered symptoms. And quite frankly, it was the winner for most patients. It was the one that most patients responded best to in terms of symptoms. But it turns out there's a dose dependence to this, right? So I think the reason why a lot of patients don't tolerate beta blockers is that they go and see a cardiologist, and the cardiologist dose the patient the way they would a patient after a heart attack. And that's with full dose beta blockade. And what we found is that as we went to fuller doses of propranolol, while the heart rate and blood pressure were lowered, the symptom improved away. So the symptoms started to get worse again. So the approach with propranolol is not to fix the heart rate, but to take the edge off the heart rate. So just a little bit of propranolol and more is not better. Ivabradine is a drug that's been on the market for about 5 years, I think, in the States, mainly for heart failure. There have been case series suggesting benefit in POTS patients, but it wasn't until earlier this year, and Pam Taub's group from University of California in San Diego published a randomized trial in POTS patients with high standing norepinephrine levels, so potentially hyperadrenergic POTS patients, showing that the ivabradine did improve symptoms. Right, so I think it was 5 to 7.5 milligrams twice a day. So there is some data for ivabradine now. My understanding in the States is that insurance coverage is still often difficult for patients with ivabradine. So this may be in theory a better treatment than in practice in terms of being able to get the drug, but there is data supporting its use. Acetylcholinesterase inhibition with pyridostigmine, it's a peripheral acetylcholinesterase inhibitor. So what that does is it increases the amount of acetylcholine that lingers because you're preventing or slowing down the breakdown. And we've shown that it does lower heart rate in POTS patients, and it improves symptoms acutely in our hospital-based setting. The truth is it's a pretty smart drug. It helps a little. It's not great. It's not potent by itself. Often I use it in combination with beta blockers. Importantly, Blair Grubb's group published a large case series where in 300 patients where over half reported symptom improvement with it, but about 20% had to stop the drug due to intolerance, and almost all of it was due to abdominal cramping and diarrhea. So if you're prone to diarrhea, I don't use it. But if you're prone to constipation, the side effect may be great because it increases gut motility, so it may actually be helpful. And the final thing I'll say is about norepinephrine transport inhibition. So typically these are drugs that are in the serotonin norepinephrine reuptake inhibitor class, or SNRI drugs. We use atomoxetine, which is an ADHD drug, but there are a bunch of drugs in this class. And this is the only drug that we use in our studies at Vanderbilt that actually worsened tachycardia and made symptoms worse, right? And that's because the norepinephrine which is what we expected actually, because the norepinephrine transporter is a sympathetic synapse clearance transporter. And so if you inhibit the norepinephrine transporter, you end up with effectively more sympathetic tone, right? So you saw that slide earlier where we're trying to decrease sympathetic tone by increasing volume. This does the opposite. So again, not everyone got worse, about 2/3 got worse and 1/3 either had no change in symptoms or felt slightly better with it, but it's unlike any other drug that we studied. So we recommend patients stay away from SNRI drugs if at all possible. So I'll finish up by saying the key take-home messages are that POTS is a chronic disorder and is associated with a lot of disability. Importantly, it's a syndrome, right? There are different ways to get there. We often don't know what the ways are in most people, and people have different features and characteristics that require individualized treatment. So there's not necessarily a one-size-fits-all for everyone. We have an approach we take, and we have to then customize it a bit. The treatment principles involve exercise, involve blood volume expansion, so salt and water, involve heart rate control. And I didn't speak about this a lot, but I've mentioned it's a chronic illness. Ultimately, patients have to learn to live with a chronic illness, and that's often a change for patients, right? You were healthy and you were doing A, B, C, and now you're not able to do all that. And there's a grief process that I've seen patients go through, and some people handle it better than others, and some people, find a way to live with it. And I'm not sure there's a one-size-fits-all answer for how to do that, right? In some people, antidepressants help, and some people, mindfulness and those coloring books help. Some people, it's yoga. It's different for different people, right? But I think it's important that people not sort of say, well, the problem's my heart or the problem's my head. The autonomic nervous system connects them both, right? And ultimately, the goal is to make people more functional, and learning to sort of, accept the chronic illness and then work on the function at that point, I think helps with that goal. So with that, I will stop, and I'm happy to answer questions.
Alrighty, that was wonderful, I have to tell you. Do you mind really quick just stopping your shared screen? Perfect, thank you. First of all, I have to say, when you were reading the salt shots, I didn't know you could see my face, but that just sounds so nasty to me.
Me too.
And I used to have to take salt tablets, of tablets of compressed salt, and I got so nauseous all the time. So that was very interesting too. And of course that there's different, types of pots, and not everyone has pots, so they can have different components. I'm very curious to see where that goes, because that was also very interesting. But a few of my questions were, is POTS autoimmune? We all know that it's your autonomic nervous system, but there's been some thoughts and mention of it having an autoimmune component, and I would love your opinion on that.
Yeah, I think, I come back to my statement that POTS isn't a thing. It's a bunch of things. And I think it's heterogeneous enough that I'd be shocked if there was one mechanism that was universal across the spectrum of patients that we diagnose with POTS. And so I think there are some patients, I think there's certainly some patients that may well have an autoimmune component to it, right? So there's a lot of smoke, right? I mentioned that 16% of patients have had an autoimmune disorder, but not always the same one. There have been a few studies, Dr. Blitchen, who I think was a former speaker in the series, as well as a study out of Mayo, where, the numbers were slightly different, but what they showed was, again, if you add up a bunch of POTS patients, and in the Mayo study, they had control subjects from the labs, there's a little more of a bunch of autoimmune things, right? Where if you add them all up, there's more autoimmunity or autoimmune disorders in the POTS patients, but not a thing. I've had, and other colleagues have had an interest in auto antibodies targeting the alpha and beta receptors, and that's turned into a fairly complicated, quicksand pit to try and sort of, understand. But I truly believe that there are some patients, especially, there are patients that present post-virally. We're seeing now with COVID, but existed before COVID, where there probably is a strong autoimmune component, but there are others where it's not.
Mhm. Okay, and a lot of POTS patients frequently feel dehydrated, or that, no matter how much you drink, you still feel lightheaded and dizzy. And do POTS patients dehydrate faster than most people?
Yeah, so I wouldn't. I think the short answer to your question is yes. I think in many cases, but the longer answer is I'm not sure. I'd say they dehydrate faster. I think there may be problems in holding on to sodium and volume, right? So I think that's part of why we know the blood volume is lower when we've looked at it overall. And the question is why with that. And some of our work involved abnormalities in the renin angiotensin system, which is responsible for regulating how the sodium holds on to sodium, sorry, not salt.
Right.
And then the water that follows. So I think that's why, quite frankly, routinely we recommend the salt and water for our patients without regard to the specific volume. In many patients, symptomatically, they notice a benefit with just that.
Okay. Well, I think you answered every other question I had in your presentation. But Ellen, do you have any questions for Dr. Raj?
I'm curious, being the age that I am, I'm very curious. We're hearing a lot from patients that are postmenopausal women who have not had POTS during their younger years, but develop it later in life. And I know it's more rare, but is that usually caused by a secondary illness, do you think? Or what's your thought on that?
Yeah, I must say I'm not sure I've seen that much of that, but you do wonder if there's a different cause, right? I mean, so we sort of mentioned that even it's gotten a lot of attention with COVID and long COVID, the whole issue of post-viral sort of autonomic features and tachycardia, but that's something that in the Big Pot survey, while most people didn't have an identifiable trigger, of the ones that did, the most common one was after a viral illness, and that could certainly occur even in the older age groups as well.
Right.
But I'd say I'd be lying to you if I told you that postmenopausal women were becoming the dominant demographic, right? It's still largely younger women that we're seeing primarily in our clinic.
Mm-hmm. I've wondered with some of the patients that I've spoken to because they'll mention that they had a lot of symptoms when they were younger, but never amounted to much. I've often wondered if they didn't have some autonomic dysfunction that just wasn't picked up on, or just wasn't severe enough, I guess, or frequent enough that they would have, been diagnosed earlier on.
It's hard to know, right? Because obviously recognition is better now than it was 20 years ago, and certainly better than it was 40 years ago, depending on how old they are now and how old they are, how long ago this was. But I'd also be careful about that, because there are lots of disorders that can cause lightheadedness that aren't necessarily related to tachycardia, right? So, for example, vasovagal syncope, reflex fainting, is the most common age of onset for that, based on prior syncope studies, was 17, right? So again, it affects people in their teenage years, and affects probably women a little more than men, but not probably more 60-40 than a 90-10. So there are other things that it could have been that may not be POTS, and it's going to be hard, almost impossible, to go back now and tease that out.
Right. Is there, I don't know, this is probably a pretty complicated question, but I often wonder if what is the best way for organizations like ours to educate the medical community? How do we have, I guess, more open-mindedness from some primary care physicians that may be the first people seeing some of these symptoms and not necessarily making a diagnosis, going more towards it's anxiety, it's, depression, whatever, without, putting all the symptoms together, especially in teenagers who may be accused of not wanting to go to school or having other issues.
Sure. I mean, it's tough. I mean, you're sort of touching upon the issue of an invisible illness and how do you get buy-in, right? And I'll say two things. The one issue with POTS, and it may not be the most important issue, but it's a clear hemodynamic issue, is the orthostatic tachycardia. If it's high enough, I think most physicians would agree it's abnormal, right? So if you start with a resting heart rate of 60 and you go to 105, that may not excite them. But if your heart rate goes to 140, I think most doctors would agree that probably shouldn't be. Now, the challenge, and I'm sure you've heard this from your patients as well, is that often the patients don't necessarily know to think about the orthostatic tachycardia, right? They don't sort of clue in with that. And they may even go to the emergency room. And from our survey, we know that people often visit many times beforehand. You may wonder how that could be. And how that could be is that you go and then they lie you down in a stretcher and hook you up, and you're lying down and things don't look that abnormal, right? And then they do some blood work, do a bunch of tests, and everything looks good. And they say, can't find anything, go home. And you get up to get dressed to leave and you feel like crap again. Right. And so it may be missed those opportunities. So if you know about the tachycardia, that's sort of a feature that's harder to quickly dismiss. And then the other part of it is I think there is increased recognition among physicians, right? And one of the interesting phenomenon is that when a physician sort of realizes that this patient has POTS and there's a thing that they have, they may find other patients in their practice that have had similar symptoms that have been unlabeled and they haven't understood, and go back and say, well, ask the question, do they have POTS? And so that's happened as well. I mean, it's a slow grassroots thing. If you were hoping for sort of a magic, shoot a bomb in the sky and it'll, everyone will start thinking about it, I don't think that's going to happen, right? It's a slow iterative process. But I think awareness is increasing. There's no doubt in my mind.
Good.
Oh, good. Well, that's a positive move forward then from where we were before, certainly. Well, thank you, Dr. Raj, for answering a few questions for us and for a wonderful presentation. I learn something every time I read something that you've done or hear something that you've said. So I appreciate that. We all do. Thank you again to our sponsor, Banana Bag Oral Solutions. Please check them out at their website to learn some more. And thank you all for attending this session. We hope to see you again next week on November 2nd for the premiere of a roundtable discussion, which is our final session in this series. And it is collaborating for better patient outcomes. We're going to have a discussion with professionals from different parts of the medical world to talk about the future and how we can improve care going forward. So on behalf of all of us at Dinet, we hope you enjoyed this session and we hope you can be well. Thank you.
Thank you all.